Hi, this is Dr. Toby, your host on Health and Wellness. Thank you for joining us. We have a special show with Dr. Segun and Tosin Lejofi. Tosin is a nurse who trained in San Jose, who trained in California, worked in Georgia, and has been working in Mississippi for the last couple of years. She's happily married to Segun Lejofi, who is a family medicine physician. He went to university in Connecticut and then offshore for medical school, came to University of Mississippi Medical Center for his residency in family medicine, and finished off just recently a one-year interventional pain fellowship. They have two lovely kids, a boy and a girl, and they're making their home in the future in Atlanta. Tosin is pursuing a medical school degree. She's been accepted to medical school and she's about to start. And I wanted to share their story of love, of passion, of desire, of faithfulness, of fidelity, of hope, of promise, of aspiration, of not giving up on their dreams. You will be blessed with their story. God bless you. Hi, this is Dr. Toby, your host on Health and Wellness. Thank you for joining us. Don't touch that dial. I have a great show with Dr. Segun Lejofi. He's a interventional pain fellowship trained. He's a family physician, and he's traveled across the nation, trained in Connecticut, trained in Mississippi, went offshore for medical school, started a practice in Atlanta in the suburbs with a pain management fellowship program. And he's going to be talking today about pain. You're welcome on the show, Lejofi. Thank you so much.
Thank you for having me.
He's married. He's a father of two lovely children, a boy and a girl, and his parents live in the Georgia area as well. How many siblings do you have?
Two. Older brother, younger sister.
Okay, I met your older brother. I haven't met your younger sister. What's she doing?
She's a nurse.
This medicine thing is strong. Jesus, wow.
Yeah, she's a nurse in Georgia. Yeah.
How far is she gone? Like RN, LPN?
RN.
RN.
Yes.
What hospital?
Emory.
Emory, okay.
Yeah.
Nice. And she's carving her niche, like administrative, clinical. What does she want to end up?
She is moving towards admin now.
Okay.
At some point, we were trying to figure out if she wanted to go the NP route, but I think she's going.
Is she younger than you?
Yes, she's younger.
Okay, that's why you can say that. If she was older, you wouldn't be telling her, but trying to figure out what you're trying to do.
No, we talk a lot, so we bounce ideas off each other.
Okay, so she wants to do more administration than NP.
Yes,
okay.
yes, at this point. Yeah.
So tell us a bit about what inspired you. Like I said earlier, you were the first in my knowledge of the family medicine world to pursue a pain medicine fellowship. There may have been others, but was there any background to this idea? I mean, you were in third year or second year when you came up with this idea to go into an interventional pain fellowship. Is that the right word for it? Interventional pain. Okay.
Yes. So there are a few people who've gone from family medicine to pain in the past. I was not able to connect with one while I was trying to apply or going through that process here. During residency, I sent or referred quite a few patients to the pain clinic. And when they came back, I was always curious about what was done over there. A lot of them were doing better. So I decided to take a rotation at the pain clinic. I went there.
So it's an elective.
Yes, it's an
It's not a
elective.
standard.
Yes,
Oh, really?
yes. It's an elective. I went there. I loved what they were doing. I'm very interested in procedures. Like my procedure month in fellowship was probably my best rotation. So I loved it. Went back for a second rotation. Um, Loved it.
That
They
was in
loved me.
second year.
No, that was in second year.
Okay.
Yeah, second year, early third year. Then we talked about possibly applying, and they welcomed the idea, and here we are.
So the question is, what do they do in? Because if I'm correct, we
Yes.
have pain management specialists.
Yes.
That's what they call them in the community. Now, is interventional pain a little subset of that pain management?
Right. So you have pain physicians who are not, who don't do interventions, and you have some that do. So if you're looking for just purely medical management, no procedures, you have those physicians, and then you have people that do a lot of procedures as well. That's medical management.
So interventional pain has more to do with procedures.
Yes. Yes.
Okay. So tell us, what do you guys do? I mean, what does an interventional pain specialist do on a day-to-day basis?
So on a day-to-day basis, you see a lot of patients. The most common diagnosis that we see has to do with low back pain. So you see a lot of those patients. You help them in terms of nerve blocks to alleviate pain. Sometimes you may have to ablate like a nerve or something like that to help alleviate pain. Um, you try to do like a multimodal approach to pain. So that means you're giving them medications as appropriate, like physical therapy, interventions, which we just talked about. Yeah, that's pretty much what we do on
what
on
do
a
you
day-to-day.
use to isolate the nerves? For example, do you use some fluoroscopy? Do you use
Yes,
some
yes. So we
guidance,
work, yeah, we work
ultrasound?
mostly under fluoroscopy, and sometimes you will do some ultrasound guided blocks, um, and we use a lot of like local anesthetics, lidocaine, novocaine, and we get as close to the nerve as possible, and we put those medicines there to help reduce the inflammation along with steroids. I don't know if I mentioned that. Yeah.
So basically, it's your training is 8 to 5.
Yes.
Were you on call
Ye-
occasionally?
Yes, you're on
Okay.
call, but you don't get
Not
called
really.
that much.
Not
Yeah.
much. Okay.
Yeah.
And you have to. I know the little I know. When you're doing the fluoroscopy, you have to put on this
Yes, a lead
jacket.
vest. Yeah.
And the reason is
Because you're trying to reduce your exposure to radiation.
Okay.
As we know, like a lot of radiation, too much radiation can lead to abnormal tissue growth. So we try to avoid that. So you have your vest, you have a thyroid shield. Some people will wear protective glasses or gloves if you're gonna be like working in the field a lot while you're using live X-ray.
okay.
Yeah.
So there's a risk if you don't use those
Yes,
gowns,
absolutely.
those
Yes.
covers. Wow.
Yes.
And this training for you was 1 year. Is that the
Yes,
standard across
that is the
the
standard.
country?
Yes.
Okay. So 1 year pain fellowship. Who are the most commonly recruited pain fellows, interventional pain fellows?
Definitely anesthesia. So
Anesthesia.
yeah, followed by physiatry, and then after that, I believe neurology, then family or emergency medicine,
Okay.
and every other specialty.
Interesting. And some of the anesthesia they don't want people to sleep anymore. That's why they do it, right?
Well, I mean,
They
it's
just want to not put people to sleep. They
right. It is definitely less stressful than the OR. I'll just put it that way. Yeah.
Oh, wow. Yeah. So, as a family physician, when you enter pain medicine, from what you've seen in the past, what are the prospects? I mean, most family physicians, do they have a dual practice? Do they have a sole pain practice? What's the regular family physician route? 10 years, 20 years? Obviously, you start working in a practice and then you build your clientele.
Right. So I can't speak of the usual routes because I don't know anyone or who has gone from family to pain.
I thought you said you heard of some people who did it,
I have heard, but I
but you
haven't.
didn't talk to them.
Right, I
Oh,
haven't met them, so I'm
okay.
not sure how they
Neither have
practice.
I. Yeah.
Yeah, but it's difficult to combine both
Both.
in a traditional sense. So most people will, from like neurology or PMNR, will practice mainly pain. Um, if you want to, you could, like, moonlight in other places, but like, having a set practice, I think could be very challenging.
So we're currently in the opioid epidemic. I
Yes.
think they said since 1999,
Hmm.
probably 900,000 or more people have died from the opioid overdose in
Yes.
America. They claim that it's about a Boeing 747 jet crashing every day.
Uh-huh.
That's how many people, and you and I know how many people are in a Boeing 747,
Yeah.
close to 300.
Yeah.
So the scenario, just to paint a picture of the opioid epidemic in America, is that a Boeing 747 jet is crashing every day, and people are dying in that Boeing 747 from drug overdose. The question for you is, in your practice, how are you going to help mitigate this opioid epidemic? Does interventional pain make a difference? Does it escalate? Does it reduce? Does it ameliorate? Does it improve the opioid epidemic?
So the goal is to reduce the use of opioids.
Okay.
What
And
I
opioids, for those watching, are,
Yes.
narcotics, and
Yes.
they can make you a
Yeah.
little dependent, and you know.
Yeah, your Percocets, your Norco, things like that. Um, my goal really is to reduce like the amount of opioids used for pain, especially like pain diagnosis that can respond to interventional procedures. What I advocate for is early referral. So when I speak with like my family medicine colleague or primary care colleagues, if you're seeing someone um, who let's take back pain for example, who has back pain, and they've done like the conservative management, which is like the physical therapy, activity modification, and medications, and they're not getting better. That's a time, that's time for you to refer them before like they get on opioids. What we do is like we'll examine them, diagnose them appropriately, see if there are any interventions that we have that can help their back pain or whatever type of pain they have. So we do that, we get them feeling better, prevent them from like getting on opioids in the first place.
So let me give you a scenario.
Yes.
21-year-old
Hmm.
female
Yes.
comes into the ER,
Hmm.
has a baby because she didn't have prenatal care,
Okay.
but she's full term, 9 months, 10 centimeters dilated. She cannot deliver. They do a C-section.
Hmm.
She comes to see me in the clinic 2 weeks
Yes.
after the delivery, and her only complaint is the pain.
Hmm.
The obstetrics and gynecologist after the C-section gave her 7 days of opioids, Narco, Percocet, and now she wants more. What would you recommend that I do in my practice as a pain management specialist? She's 21. She's had a C-section. Maybe she had an epidural along with it, and now she's complaining of pain that is unrelenting.
Okay, so we could look at that. There are different types of pain, right? So is her pain more neuropathic? If it is, then we have to like use medications that are tailored to neuropathic pain. So for someone who's just had surgery, we could have disrupted a nerve that's causing that pain. So we could use medications such as like gabapentin, for example. Um, to help with her pain. So it doesn't always have to be opioids. NSAIDs are okay to use as well, or acetaminophen. So we just have to like use that multimodal approach.
Yeah. I notice you guys
Yeah.
like this acetaminophen drip now. I see
Uh,
it quite a lot.
some people do.
Okay, so it's specialists,
Right.
particular specialists.
Right.
Okay.
I don't just because like I'm mostly outpatient.
Mm.
Um, But like, typically if someone takes like 1,000 of acetaminophen, that would usually work for pain. Um, so that's how I would approach it. Not just with like, it may be okay in some cases to like, give more opioids, but you definitely do not want to rely solely on that. You want to use your other medications that supports like the diagnosis.
So in your practice, what do you think is more common? Neuropathic pain, musculoskeletal pain, the nociceptive. Nociceptive, I believe,
Hmm.
means like abdominal-like area or just nerve
So
kind of
nociceptive can be like, visceral or
visceral.
somatic,
Okay, yeah,
right?
kind of around
Yeah.
here. So which one do you see more
We
as a
see
pain medicine, as a pain specialist?
a lot of nociceptive pain. So we see a
Mm.
lot of like, axial pain. And like I was saying earlier, a lot of what we see is like, low back pain.
Mm.
Um, you see a lot of like, neuropathic pain as well. So people with like diabetic neuropathy, chemo associated neuropathy or radiation associated neuropathy. Those are like the kind of people we see mostly.
So the American, I think it's, I don't know if it's the American, I know the CDC came out with a pain
Yeah.
guideline in 2021 or 2022.
Hmm.
And basically they're now saying there should be limited pain protocol medication after 7 days.
Yeah.
That most people should resolve their pain within that 7 day window. Is that what you've seen? Like this pregnant woman who had a C-section,
It, it
you know?
It is a little challenging just because people respond a little differently. It's not uncommon to see people on opioids like, 2 weeks later. And you also see people who were on opioids for like 2 or 3 days after their
So
surgery
it should be
stopped.
individualized.
It is individualized. It depends on how extensive the surgery is. And also, I'm a very big advocate for, at the beginning, don't just use opioids. Like, incorporate other medications that address like other aspects of the pain of your patient's pain. So if you can use your gabapentin, like you use it. If you can use your TCAs, you use it. If you can use something like Cymbalta, for example, use it. All those help, reduce pain. And if you're doing that, you're definitely reducing like the dependence on
The
the opioids.
dependency on
Yeah.
opioids. In fact, that's the excuse now for the marijuana. They said, at
Yeah.
least I'm not getting dependent on
Yeah.
opioids. And I'm like, I don't know if that's totally true. Because a lot of us still have this belief that marijuana is a gateway to other things.
Mhm.
So, and the statistics are showing that the use of marijuana is actually escalating morbidities and mortalities.
Yeah.
So it's still a question in the science, but a lot of doctors are concerned about it. That's why in UMC we don't prescribe marijuana.
Yeah.
You know, have you used the ketamine infusion? What protocol? What use do you see of the ketamine?
So ketamine can be used for like different things, including like retractive or uncontrolled depression, anxiety, and pain. Um,
There was this famous star who had a ketamine overdose recently.
oh,
Yeah, so there's been a negative publicity, just like
right.
Propofol after Michael Johnson.
Michael Jackson.
This one, there was a
Yeah.
ketamine. I'm trying to remember the name of the movie star, but it was a pretty popular person.
I was not aware of that.
You know.
I'm not up to date on on my how do you say it? But no, we use ketamine for example, people who have like fibromyalgia. You can use like a lidocaine infusion or a ketamine infusion. Some of them respond really well to it, and may have to like have an infusion like every 6 weeks or something like that. So you have a subset of people who like benefit from it.
Okay.
Yeah.
So your protocol is get them in early.
Yes.
Try to avoid opioids to the best of your ability.
Yes. Yes.
Obviously, when you get to the point where you need it, then it's inevitable.
Yes. Yeah, it has its role in management of pain, either like, in the acute phase of things, or I mean, the acute phase of the diagnosis, or, if, you're talking about people with like, cancer or cancer-related pain, it's appropriate in those areas as well.
And that's the biggest question we all have about the interventional pain referral. A lot of people say only refer chronic pain. In our textbook, chronic pain is 6 months.
Right.
So, so the question is, do I wait 6 months, try everything, then refer? Or do I intervene early when it's still questionable whether it's chronic or acute?
So what I actually like to do now is like, not use the timeline.
Okay.
So if you expect someone to get better or pain to improve, say in like 6 weeks, and you're at the 8th week and it hasn't improved, that's not chronic pain. Right. So that's a good time to send them over and say, hey, this person has this condition. We have done X, Y, Z. They're not improving. What would you suggest? Yeah.
Interesting. Because that's kind of the nomenclature that we're seeing
Yeah.
in our current generation. So the statistics show that Mississippi had the highest death rate from opioid overdose, like 125 per 100,000. I have had patients come to my clinic and they're totally zonked out. When I call the EMS, take them to the ER, this guy was high on fentanyl.
Yeah.
So tell us a bit about fentanyl. And I've seen the effect on a patient. In fact, my concern with this same patient I'm talking about, 29, 30 years old, when I started seeing him, he's about 37 now, is that he from that hospitalization, he went to rehab, did 3 years, he's been doing well, but he keeps coming back asking me for Lyrica and gabapentin. He wants narcotics, but obviously he knows I'm not going to give him narcotics. So my question is, when you see people who have that predilection or history,
Yes.
we try to avoid any narcotics at all. So gabapentin, Lyrica, the question is, are they opening doors in the brain? So I'm being very careful with him. Right now he's on gabapentin.
Okay.
He doesn't want Cymbalta. So that's just another example of someone who I want to be careful not to push over the cliff.
Right. Right.
And I've sent him to pain management, but he doesn't really go. So that's a challenge with people like that.
No, using gabapentin or Lyrica is totally fine. Some people describe the feeling of feeling a little foggy with either gabapentin or Lyrica. Some people may enjoy that, but like from the standpoint of addiction and dependency, not so much as we see with opioids.
Why do you think the South has such epidemic? Because I mean, they said Connecticut was the lowest in the country for drug overdose deaths.
Yeah.
The lowest. Mississippi was the highest. Connecticut was like 32.5. So the South should be, church bell, Bible bell, should be doing the right. So do you think from your history of working in Mississippi, what do you think is the #1 cause of the opioid epidemic in Mississippi, where we have the highest in the nation of overdose deaths?
So this is multifactorial, right? And we know that your social economic status has a lot to do with these things. So when you're in an area where if you look at Mississippi traditionally, well, I shouldn't say traditionally, over the last decade, for example, when it comes to health outcomes, Mississippi is dead last in a lot of those things. So when you look at that, you look at what options people have in terms of health care, in terms of access, in terms of social economic metrics. When those are poor, I believe that that opens doors for a lot of these things to happen. So I think that's definitely one of the highest things.
So you're telling that 25-year-old mother who has a 16-year-old drug addicted son who's dropped out of high school that it's the financial insecurity that is pushing her son.
Well,
towards drugs.
I mean, I think definitely in poorer areas it's more prevalent. What
A lot
you
of people
should
think
be.
it's the lack of a father figure, but that's a relative discussion. Some people say it's just lack of oversight.
So family
the
structure
young.
plays a big role in how we develop a lot of the things we decide to do or not do. So if you're missing that family structure, that is a big thing. Secondly, even if you don't have that family structure, if you have like a role model or mentorships, those can help as well. But when it comes to like just purely addiction, if you have someone who is addicted, get them help. There are rehab facilities that can help you with like little or no payment.
Yeah.
Yeah,
And it cuts across the board. I mean, there are multi-millionaires who are addicted to
absolutely,
opioids, and
absolutely.
some
Yeah,
of the, I have a patient who's 18, and the mom just tells me that he's so high on drugs that he's just stealing everything he can see to get drugs.
yeah, yeah.
And I told them, bring him in, take him to, the mom just says he doesn't want to go. And I'm like, does he have a choice? I guess he's 18 now, but he lives under her roof, you
Right.
know.
Well, they have a choice to or to not get treated. It's just a matter of you have to like constantly work with them. Um, when it comes to like the resources they are using to like get like substances. If you're in control of it, then you may want to like limit that. But in this case, he's stealing to get it, so
Yeah.
it's really not much you can do
So the
about that.
challenge we all have is how do we as a community reduce the opioid epidemic? Referrals to interventional pain medicine, reducing to the bare minimum the need and the use of it,
Yeah.
and advocate for people to get treatment and therapy as needed.
And because a lot of the times, like people get exposed from leftover medications at home. So if you had surgery, dental procedure, you didn't use your Percocet or your Norco,
Right.
dispose it appropriately. Don't just leave it hanging in the house. Um, yeah, that's usually one of the ways people start.
That's crazy.
Yeah.
Well, we've been talking to Dr. Shegun Lejofi about the pain opioid epidemic. Now, pain is real. The opioid epidemic is also real.
Yeah.
The question now is how can we manage both without tipping the generation that is coming over into overdose? We know we have cancer patients, sickle cell patients, chronic pain patients who still require the need of opioids. But the problem is a lot of people who are not necessarily supposed to be on opioids are getting their hands on these medicines. People who have dental extractions, people who have, toenail pulled, and, they want opioids. I think that's where we have to be careful with how we prescribe those medicines as physicians. We've been talking to Dr. Shegun Lejofi. He's been sharing his heart with us. We'll be back next week on the final segment of the show. Thank you so much. Jesus is Lord. God bless you.